Given time is 6 minutes. Please try to wind up within that.
Shall I start? Good morning, everyone. I'm going to present my study on use of topical insulin to treat refractory neurotrophic corneal ulcer. To begin with, neurotrophic keratopathy or corneal ulcer is a rare degenerative condition characterized by decreased innervation of the cornea, causing epithelial breakdown and poor wound healing. It affects less than 1.6 per 10,000 of people. Treatment options include lubrication alone to multimodality management, including aggressive topical and surgical treatment. Now, a neurotrophic keratopathy becomes refractory when it is unresponsive to conventional treatment. And nowadays, studies on topical insulin shows that in low concentrations, it is a promoter of cell migration, it stabilizes corneal enzymes and regulates its biological environment, and is also safe for topical ocular use in humans. So, the aim of our study was to evaluate the efficacy of topical insulin drops in treatment of refractory neurotrophic keratitis and to analyze how it may improve epithelialization. So it was a prospective, non-randomized, interventional, hospital-based study on 8 patients visiting a tertiary eye center. It was done between August 2021 to February 22, and neurotrophic keratitis unresponsive to medical treatment were included in our study, whereas those resulting into corneal melt or perforation were excluded from our study. So how we had prepared topical insulin drop? It was prepared by mixing regular insulin in artificial tear with polyethylene glycol and propylene glycol base at a concentration of 1 international unit per ml by a sterile technique, and topical insulin drop was prescribed 4 times daily and bandage contact lens was applied. The measurement of persistent epithelial defect area was done. The treatment was continued until persistent epithelial defect or ulcer resolved and was tapered accordingly. So patients' demographics, NK etiology, concomitant treatments, and comorbidities were reviewed. Approval was taken from Institutional Ethics Committee, and the tenets of Declaration of Helsinki were followed. So coming to result, we had 8 patients, 3 of which were females and 5 were males, with a mean age of around 52.75 years. The comorbidities included herpetic eye disease in 3 of the patients, chemical injury in 1 patient, lag ophthalmos in 1 patient, uncontrolled diabetes mellitus in 1 patient, and past history of ocular surgery in 2 of the patients. The AIOC patients, that is 87.5%, had reepithelialized, and 1 patient still presented with an epithelial defect, although it had decreased in size. The mean persistent epithelial defect area before treatment was 15.87 millimeters square, which reduced to around 1.1 millimeters square after treatment. The range before was 3.75 millimeters square to 32.5 millimeters square. The mean area in reduction of persistent epithelial defect area was around 93.7%, which is quite significant, and as shown in the line diagram. Now, the mean time until reepithelialization was 13.375 days, which ranged from 7 to 21 days. No side effects were reported during treatment. As we can see in the diagram, 2 of the cases, in case 1, complete reepithelialization was seen by day 14, whereas in case 2, it was seen by day 21 of treatment. Now, we know insulin-like growth factor 1 or IGF-1 is an important modulator of corneal wound healing. In several preclinical studies, IGF-1 acted synergistically with substance P to promote corneal epithelial wound healing. The presence of insulin receptors on cornea and lacrimal gland and increased prevalence of keratopathy in diabetic patients suggests that insulin may contribute to corneal wound healing. And N.K. Wang et al. Described topical insulin for sterile refractory neurotrophic ulcers from various pathologies that reepithelize within 25 days after starting topical insulin drops 2 to 3 times daily. Galvez et al. Described a case of exposure keratopathy that progressed to an infected neurotrophic ulcer after acoustic neuroma resection. Topical insulin, 1 international unit per ml, was used as an adjunctive therapy to topical antibiotics. Besson and Link suggested that 50 international unit per ml topical insulin might improve the rate of epithelial wound healing, whereas Phi et al. Found that 25 international unit per ml was associated with better healing. So they had used a higher concentration as compared to our study. Now, the limitations of our study was heterogeneity in the patient presentations, differences in treatment duration, and lack of a comparative control. To conclude, topical insulin may be a simple and effective treatment for refractory neurotrophic corneal ulcers, and additional advantages are also there, like excellent tolerance, availability, and cost effectiveness. Thank you.
Thank you, Dr. Sujitra. Any questions on the panels?
What is the shelf life of these drops, and how do you store them?
Pardon, sir?
Shelf life of the drops which you made.
We had refrigerated it. We used to keep it in refrigerator for 1 month. We didn't use it after 1 month.
Okay.
Okay.
Which insulin?
Ma'am, Act Rapid. The insulin injection we had used. If we had 3 ml bottle of PEG and PG drops, we used to put 3 units of international unit by the pen.
Okay, I have two questions. One, you did not classify the neurotrophic keratitis initially. You had only 7 or 8 patients. So were they of which class? There is a METI classification, if I remember.
They mostly came to us when it was in stage 2. Stage 3 were excluded from our
Okay,
study.
you didn't take stage 1. You went for stage 2 and stage 3.
Mostly they were in stage 2. So stage 3 were
Okay.
already excluded,
Okay.
and stage 1 they didn't know they had. They came to us in stage 2 only.
Okay,
Sir.
okay, that is one. Second, similar studies were already published. So what is the new message you are giving?
So actually, I wanted to see the results in our area.
Anything
Not
different from
my
the previous study? There is another study, I think 17 or 18 by Wang et al. That you were mentioning.
Yes, sir, I have seen. So I
Okay.
didn't see similar study in around. I didn't see like.
What is the difference? What was the difference in this study from that?
So like this works in poor peripheral areas where we can't use serum, autologous serum eye drops or AMT and other procedures. We can use topical insulin in those areas.
Okay.
Like ours, we can't do AMT and the other serum eye drops for poor patients also. Like topical insulin is affordable for them and it's like easily accessible. We can do that. So we can use that for those patients.
Okay, well done.
Thank you. Dr. Nayana? Dr.
Rashmi.
Okay, okay. No problem. Kariye. Yeah.
Abhi nahi aaya.
Good morning. Can I start?
Someone stuck up in the traffic.
At the outset, I would like to thank AIOS for the opportunity to present this paper. There are nil financial disclosures. To start with, to look at the management of keratoconus, in the early cases where the thickness is adequate, the options include collagen cross-linking or a combination with ICRS or PRK where contact lens intolerance is there. But in advanced cases where the corneal thickness does not allow collagen cross-linking, patients are usually subjected to contact lens for visual rehabilitation, and when they are contact lens intolerant, they await keratoplasty. Recently, there has been some exploration in the field of volume addition techniques to improve outcomes in patients who have advanced keratoconus and not suitable for collagen cross-linking. However, this is limited by global shortage of donor corneas, and recently in the pandemic, it was also seen that the procurement of the human transplant tissues was difficult. So this prompted some unanswered questions. What is the role of intrastromal implants and how helpful are they in advanced keratoconus that is not suitable for collagen cross-linking? And secondly, what are the visual and topographic outcomes of xenogenic implants in advanced keratoconus cases? So the aim of the current study was to assess the outcomes of intrastromal implantation of porcine collagen lenticules in subjects with keratoconus that are not suitable for collagen cross-linking. This was a prospective open-label clinical trial, and a sample size of 8 was sufficient to achieve the endpoints. Descriptive statistics was used to analyze the results. Patients of more than 18 years of age with advanced keratoconus but a corneal thickness of more than 350 microns and who were contact lens intolerant were included in the study. And patients with previous ocular surgeries, corneal scars, poor ocular surface, a corneal thickness of less than 350 microns, and pregnant and lactating mothers were excluded from this study. All the patients underwent a slit lamp evaluation, corneal topography, in vivo confocal microscopy to look for changes around the implant, and corneal OCT at preoperative and every postoperative visit. So looking at the porcine collagen implant, it's called Xenia, which is a lenticule derived from anterior corneal stroma of the porcine cornea. It undergoes a 4-step process of decellularization, washing, compression, and then cross-linked with ultraviolet radiation to make it biomechanically stiffer. It is then around 90 to 100 microns thick after the compression, and it is around 7 to 8 millimeter diameter, available as a disc. So how the surgery is done is a femtosecond laser-assisted stromal pocket is created, and the Xenia lenticule is inserted into the pocket using a McPherson forceps or an injector, and then the lenticule is unfolded and centered in the pocket. Coming to the results, in all the postoperative visits, all the patients maintained a healthy interface, and there was a significant improvement in uncorrected and best-corrected visual acuity. In the OCT pictures, we could see that the lenticule was well placed in the anterior stroma, and there was a significant increase in the thickness at 1-year follow-up. When we look at the corneal topographic results, there was a significant flattening which was seen at 6 months as well as 1 year. In the in vivo confocal microscopy, changes were seen in the form of dendritic cell densities in the anterior as well as posterior interface. Within the lenticule, there was no stromal keratocytes or any inflammatory response, nor was there any subbasal nerve plexus infiltration in the lenticule. And these were the dendritic cells and activated keratocytes in the posterior interface. Looking at the summary of the results, the uncorrected as well as the best corrected visual acuity improved at 6 months as well as 1 year. There was a significant keratometric flattening seen at 6 months as well as 1 year. Improved corneal thickness was seen, and the anterior corneal astigmatism showed a significant improvement. There was no significant improvement in the posterior corneal astigmatism, which could be due to the fact that the stromal implant was placed in the anterior part of the stroma. In the confocal microscopic changes, we saw that the dendritic cell density was significantly increased only up to 6 months of the surgery, but it came down to normal at 1 year, and the keratocyte density was insignificantly changed. Now, stromal keratophakia is known for treatments of myopia, aphakia, as well as hyperopia, because it changes the corneal curvature, and that is the mechanism that is used to correct the refractive error in those cases. Recently, stromal lenticule implantation has been explored in advanced keratoconus, which is not suitable for collagen cross-linking as well. But this global survey in 2012 was conducted, which showed that almost 50% of the patients in the world who require a corneal transplant tissue do not have one, and there is one cornea available for at least 70 needed, which prompts everyone to think about whether there is an alternate for human corneal transplant and to look at xenogenic transplants. So why looking at porcine collagen is because it is anatomically and physiologically more similar to human cornea. More so that recently it has been confirmed that it also has a Bowman's layer similar to human cornea. So Xenia lenticule is a porcine collagen lenticule that is derived from anterior corneal stroma, undergoing decellularization to wash off all the keratocytes and the antigenic epitopes, then washing and compression to reduce the thickness, and finally cross-linking. A study has shown that they are 50% thinner than the original tissue procured, and at least 120% higher biomechanical stiffness is achieved. So we found that Xenia had the advantages of being less complex as compared to keratoplasty, can be done under topical anesthesia without any sutures. It reduces the risk of rejection because there are no antigenic epitopes, and there is a faster procedure outpatient. And it is a reversible technique as compared to keratoplasties. So to conclude, the study concluded that porcine collagen implants can successfully improve the visual outcomes in patients who are not suitable for collagen cross-linking. They can flatten the corneal curvature, add volume to the already thinned out cornea. There is reduced risk of rejection, and it can be seen as a novel alternative technique for volume replacement in cases with thin corneas not suitable for collagen cross-linking. Thank you.
How long was your follow-up, Rashmi?
1 year.
1 year.
This is the 1 year results, ma'am.
Okay, so there was no extrusion or anything like that?
One patient we had explanted because they were not able to maintain follow-ups. So at 3 months only that patient was explanted.
Okay, and how the interface? Because any tissue you put inside has 2 layers of interface. So did you do any aberrometry or any eye trace or something like that
No,
to see the interface?
The confocal microscopic and topographic changes that we have looked at in this study. I showed the images of the anterior as well as the posterior interface by confocal microscopy. So the keratocyte density has not changed over time. The dendritic cell density was changing, initially showing more inflammatory response, but it came down after 6 months. So till 6 months of time, the dendritic cell density was significantly higher, but at 1 year it became insignificant.
But how is the clarity of vision? You can say the line acuity may be there, but how was the clarity?
So we have also done low contrast visual acuity, and that also was significantly improved. In the interest of time, I have not included that data in the paper.
And how
here.
many lines of improvement did you find? Was
We
it
found 1.5 to 2 lines of improvement when it came to low contrast
BCVA or
visual acuity.
UCVA?
This is BCVA that I'm talking about, ma'am.
And did they need
Spectacally
contact
corrected
lenses
visual
or something
acuity.
like that?
Sorry?
Did they need contact lenses
No,
fitting
ma'am.
after
So
that?
patients who were contact lens intolerant were taken in the study.
And
Because if
after
they are
you put
suitable
it,
for contact
how much
lenses-
did the thickness increase?
So thickness increase I have shown in it improved from 354 to 387 in the 6 months according to the study, and in the final visit also it was around 389. So around 30 to 40 microns increase, which shows statistical significance. But
And
of
what
course
was the
sample
thickness
size
of your
was
lenticule?
90 to 100 microns.
And did it compress itself? Did it absorb? What happened
So
to
the
it?
fact that it was not a 1 plus 1 2 equation when it came to pachymetry improvement, because the pachymetry improvement was 40 to 50 microns, we thought that there might be some amount of stromal compaction or the lenticule compaction after it was inserted. But of course,
Okay.
we have a 1 year follow-up only.
And you cross-linked it or it came
It
cross-linked?
came cross-linked. It was a suggestion given.
So there was around 50% decrease in the thickness at 1 year. What thickness was implanted? Approximately. So you implanted a 90 micron thickness lenticule,
Yeah.
and
Yeah.
there was increase of around
Yes.
35 micron. So that
Yes,
was
that is
significant
why it was
compaction.
increased,
Normally
and
we
it
see
was-
around 20 to 30% compaction of any human lenticule that if we use,
True.
but it was much more than that.
True. But also that it acts like a splint almost, because it's quite a stiff thing when you put it inside as compared to when we insert a smile lenticule or a donor-derived, human corneal donor-derived lenticule. It is a little stiff when you are inserting it.
Which femtosecond you used?
Wave light, sir.
Wave light.
Yeah,
Okay.
yeah. There's an option of stromal pockets.
Okay, and there was interface haze as is seen in this at 1 year also. Significant haze is still visible in this. So this was this is one patient.
The visual axis was clear, sir.
Okay.
Okay. In the edges of the pocket, you might see a little bit of haze there, but the visual axis has remained clear, and that is why the visual acuity was also seen to be improved.
Okay.
But
Good
there was
stuff.
no significant scarring there in the center, at least.
Thank you. Excellent presentation. We call upon Dr. Vaidehi. Vaidehi. Vaidehi? Yeah, her presentation is ready.
Can I start?
Yeah, please.
Good morning, everyone. I'm Dr. Vaidehi Rao. The topic of my presentation is outcomes of Decimal stripping endothelial keratoplasty in iridocorneal endothelial syndrome. Iridocorneal endothelial syndrome is characterized by structural and proliferative abnormality of corneal endothelium leading to corneal decompensation and glaucoma. It includes a spectrum of 3 clinical variants such as essential iris atrophy, Hogan-Reeves syndrome, and Chandler's syndrome. Corneal decompensation in ICE syndrome was managed traditionally by penetrating keratoplasty, but recently posterior lamellar keratoplasty techniques like DSEC and DMAC have been tried. The objective of our study is to evaluate the outcomes of DSEC to manage corneal decompensation in ICE patients with concurrent or sequential surgical intervention for glaucoma. A retrospective study was done from January 2017 to December 2021, in which 11 patients with ICE syndrome were included who had undergone manual DSEC for corneal decompensation with or without combined surgical procedure for glaucoma, either with trabeculectomy or RD implantation. All surgeries were performed by a single cornea and glaucoma specialist. Post-operatively, data was collected at 1 week, 1 month, 6 months, 1 year, until last follow-up visit. The parameters assessed at each follow-up visit were best corrected visual acuity, intraocular pressure, and graft clarity. Moving on to the results, the mean age of the study group was 53.36 years, and out of the 11 patients, 6 were females and 5 were males. The indications of DSEC were primary corneal decompensation due to pathology of ICE syndrome in 9 cases, and secondary corneal decompensation due to RD tube touching endothelium in 1 case, and due to iatrogenic decompensation after cataract surgery in other case. Next, the visual outcomes. The mean preoperative vision was 1.39 and the mean postoperative vision was 0.47. The postoperative vision was maintained in all the patients till last follow-up, except in 1 case where we had secondary graft failure, and the post-op visual acuity in 1 case was 6/60 due to pre-existing anterior stromal scarring. Here in this table, we compare the visual acuity of patients in whom glaucoma surgery was done before and after DSEC, and we compare their visual acuity pre-operatively, immediate post-operatively, and during last follow-up visit. In these, we have obtained a significant improvement in vision in immediate post-operative period. Similarly, we have compared IOP between the patients in whom glaucoma surgery was done before and after DSEC. But the IOP in these two groups remained the same. There was no significant difference in the IOP, and even in the pre-op and post-operative IOP, there was no significant difference. The mean duration of graft clarity was 2.18 months. The graft clarity was maintained in all patients till last follow-up except in one case where regraft was needed. Along with DSEC, cataract extraction was done in 9 cases and RD tube trimming was done in 1 case. In all our cases, RD tube implantation was done in vitreous cavity except in this case. There were no intraoperative complications, and in postoperative complication, one case had graft failure which occurred 3 years later and for which regrafting was done and the graft was clear till last follow-up. One case needed rebubbling. All the cases had pre-existing glaucoma, which was managed medically and surgically. All the cases were on post-operatively AGM, except in 2 cases which did not require AGM. Then the surgical interventions included peripheral iridotomy for 2 cases, trabeculectomy for 2 cases, and RD implantation in 7 cases. Moving on to the discussion, surgical management in the form of DSEC is characteristically challenging because of the multiple anterior segment anomalies such as intraoperative IOP fluctuations, difficult lenticule insertion, and air tamponade. Here we have compared our study with similar studies conducted by AIOC et al. And Feigenbaum et al. And in this we have obtained results in the form of visual outcomes and follow-up duration which are comparable. Technique of graft insertion. The technique of graft insertion and opposition is a rate-limiting step due to the complex anterior segment structure in eyes. In our study, we had used TACO method in 5 cases and suture push-through in TACO in 7 cases and suture pull-through in 5 cases, whereas Feigenbaum et al. Used TAN glide or Busen glide in all the cases, and AIOC et al. Used suture push-through in all cases. In our study, graft clarity and survival rates in both methods are comparable. Though endothelial keratoplasty restores visual acuity, control of glaucoma is a significant factor which affects the long-term prognosis. In spite of high incidence of RD surgery in our study group, graft clarity was maintained in all the cases except in one case where regrafting was needed. Multiple anterior segment anomalies, need for additional surgery because of pre-existing glaucoma, and difficult graft insertion technique can all lead to more chances of graft rejection and need for lifelong immunosuppression. There was no significant difference in graft clarity and IOP control between patients in whom RD implantation or trabeculectomy was done before and after DSEC. An important contributory factor to this might be RD tube implantation in vitreous cavity. Though caution should be advised to avoid damage to the graft by GDD if the procedure is planned later. To conclude, though the literature documents scarce results of favorable long-term outcomes, our study shows optimistic outcomes of DSEC with graft survival with good IOP control in eyes cases with surgically managed glaucoma. These are my references. Thank you.
What was your longest follow-up?
Longest follow-up was for 60 months.
Okay. And they have fantastic results. Did you ever do, you didn't mention any synecholysis or anything in any procedure. Did you need any other additional procedures?
Pass release
during
was done during DSEC. Like first pass release was done and after the
There was no bleeding or anything like that?
No, not significant.
It was not there. Okay. And did you do multiple iridectomies at that time or you didn't do anything like that?
No, trabeculectomy was done in 2 cases prior only. After that only RD surgery was done in some 5 cases later on.
And did they ever progressively form synechiae later on? Ice is known to progress, isn't it?
Yes.
None of them progressed?
No, synecholysis was not done.
No, I mean to say, after the procedure, after the DSEC, did synechiae continue to form? Did the ice syndrome progress or anything like that?
Till now, they have not formed. In later on follow-up visits, like we have to see.
You're following up with gonioscopy and all that after
Yes.
that? Yeah.
So you have addressed 2 aspects of eyes very well, that is cornea and glaucoma. Another one what ma'am was mentioning was iris. So management of iris, pupilloplasty, breaking the synechia, that is again one extremely important procedure which determines the outcome. I think every corneal surgeon will agree these are one of the most difficult and challenging cases. And you have done it well. It was good study.
Thank you. Wonderful presentation. The next speaker, Dr. Naina is there. Yeah.
The author is a non-ratified member. We'll give marks. Let them write. They can take a decision. Then directly focus on.
Good morning, everyone. I'm Dr. Nayana T, and my topic of presentation is thyroid hormone profile and vitamin D levels in keratoconus patients. We all know that keratoconus is a non-inflammatory disorder which presents as progressive thinning of the cornea secondary to various unknown reasons. In order to find out these reasons, during literature search, we found studies showing upregulation of thyroid hormone receptors in the cornea of keratoconus patients and lower serum vitamin D levels. We also found that both these hormones bind to similar kind of receptors. The purpose of our study is to assess the thyroid hormone and vitamin D levels in all the keratoconus patients and to know if there is any deviation from the normal range. Coming to methodology, ours is a prospective cross-sectional study in a tertiary eye care hospital where 50 patients with presence of clinical or topographic evidence of keratoconus in one or both the eyes were included in the study. Detailed history was taken. Uncorrected and best corrected visual acuity was determined. Slit lamp examination was done. Intraocular pressure measurement was done with Richard Tonopin. Automated keratometry, dilated fundus examination, dilated retinoscopy, and presence of scissoring reflex was noted. And corneal topography was done with serious topographer. All the patients who were found to have keratoconus, they were subjected to serum free T3, free T4 and TSH and vitamin D levels, which were estimated by CMIA method. And all the procedures were done as per hospital protocols to prevent COVID infection. Following patients were excluded from the study. Patients who had history of treatment for thyroid gland disorders, vitamin D deficiency, previous corneal surgeries, history of previous trauma to the eye, any chronic or acute liver diseases, and history of usage of drugs which influence the thyroid hormone and vitamin D levels. Statistical analysis was done by Microsoft Excel and GraphPad Prism software. Analysis of variance test and Kruskal-Wallis test was used to compare the studies, two samples, and the strength of the linear relationship was found with Carl Pearson correlation coefficient method. All p-values less than 0.05 was considered statistically significant. Ethical clearance was obtained from Institutional Ethics Committee. Coming to results, we have compared age in years and number of patients. From the first bar diagram, you can make out that most of the patients were in the age group of 20 to 30 years of age, and there was no proper sex predilection present. The male to female ratio was almost equal among the patients. And the best corrected visual acuity of about 90% of the patients was equal to or better than 6/18. And on anti-segment examination, about 18 patients had normal anti-segment, and a few others had findings like Fleischer's ring, prominent corneal nerves, apical corneal thinning, macular corneal opacity, Vogt's triad, etc. Intraocular pressure and fundus examination was found within normal limits in all the patients. Coming to thyroid hormone level estimation, 4 patients had decreased free T3 levels, and 1 patient had raised free T3 levels, and 45 patients were within normal limits. In free T4, only 1 patient had raised free T4 levels, and 2 patients had raised TSH levels. Here we have compared TSH levels, free T3, T4 and TSH levels among different age groups. We can see that in the age group of 10 to 13 years, the free T3 is slightly more compared to more than 14 years. And in the free T4 group, the T4 is slightly less in 10 to 13 years compared to more than 14 years. TSH was almost within normal limits in all the age groups. And coming to vitamin D levels, we found that 90% of the patients had vitamin D deficiency, 4% had insufficiency, and 6% was within the normal range. This is a scatter diagram depicting the relationship between age and vitamin D values of these patients. Here we can see that lesser the age, lower was the serum vitamin D levels. Coming to discussion, etiopathogenesis of keratoconus is not yet identified, but 2 studies demonstrated a polymorphism of vitamin D receptor genes and attributed an association between thyroid disorders and vitamin D. So thus in our study, we evaluated both thyroid hormone and profile and vitamin D levels in our keratoconus patients. So in our study, we found that 16% of the patients had deranged thyroid hormone levels, which are in line with Solon Thanos et al. Study. Vitamin D levels in keratoconus patients, in our study, the mean was about 13.5 plus or minus 8.6. Our study found significantly lower vitamin D levels in 94% of the patients, where 90% had deficiency and 4% insufficiency. And as I mentioned earlier, younger patients had lower serum vitamin D levels compared to that of elder keratoconus patients. Further studies at molecular level and corneal receptor level can help us find the exact pathogenesis of keratoconus to see if there is any correlation between deranged thyroid hormone levels and vitamin D deficiency in causation of keratoconus. The limitations in our study are that only keratoconus patients were taken as subjects, and we have not really compared healthy individuals for comparative analysis, and all the patients in our study belong to the same ethnicity. In conclusion, in our study, there was a significant decrease in vitamin D levels in keratoconus patients, and we also found deranged thyroid hormone levels in these patients. These are my references. Thank you.
Based on your study, can you conclude that keratoconus patients per se have decreased vitamin D levels, or it is there in a general population? If you check, it doesn't mean that if there is low vitamin D, there would be keratoconus, vice versa. I mean, can you give some conclusion like that? Because this is pretty inconclusive.
Yes,
Whether
because we
thyroid
have not
or
compared
this.
the normative age group with the study. That is one of the limitations of our study.
That is a
But,
major limitation. You know,
but
because
90% of the patients having low serum vitamin D levels cannot just be a coincidence. So that
in
has to-
general population, if you see, and depending on the kind of work environment, if they are office goers, if they are like our OT staff, if you take, most of them will have vitamin D deficiency. So I don't think you can really come to that conclusion. I mean, it's still needs further elaboration, isn't it? Yeah.
Did you give these supplements to these patients and then observe them?
Yes, sir. All the patients who had vitamins D deficiency were referred to endocrinologist, and
Did you follow them? Followed up those patients
followed
after the
up,
supplementation? And
after
was there
supplement-
any stabilization in the Kmax or something?
Actually, we have done C3R also for those patients, so we don't know if it is because of the C3R or it was because of supplementation of vitamin D.
I think it's just an association, but it's a document.
Maybe an association.
Yeah. Yes, but we can do a lot of work on that and see.
Yes.
Thank you.
Thank you, sir.
Murali sir.
Dr. Muralidhar.
Yeah, very good morning. Yeah, it gives me immense pleasure to share our work. This acronym is called a selective endothelectomy in a Peters anomaly, which was originally concepted, innovated, and pioneered at LV Prasad Eye Institute for the last 10 years. Myself, Muralidhar Ramappa, I focus on a pediatric cornea. My co-authors are Divya and Sunita. None of the authors have any proprietary interest particular to this particular talk. As we all know, Peters anomalies are one of the most common anterior segment developmental abnormality, which present as a central or a paracentral corneal opacification, accounts for nearly 50% of children born with a congenital corneal opacity. Bilaterality is seen in about 2/3 of the cases, and it is also incidentally one of the commonest indication for a penetrating keratoplasty, both at LV Prasad data about last 30 years, as well as a EBA, which accounts nearly 65% of all penetrating keratoplasties being performed for a Peters anomaly in children. So this picture clearly depicts, you have a central island of opacity. The OCT depicts there is a defect in the posterior lamella. And as I said, bilaterality is a 2/3, and unilateral diseases are recalcitrant, moving to the significant amblyopia. It's similar to the unilateral cataract. And there are opacities which encompasses entire cornea, where UVM actually helps us deciding whether it is a type 1 or a type 2. Where a lens, you could see the anterior lens capsule. It is a typical type 1. And this is a type 2 where you have a keratolenticulo iridodystenesis. It's a lens is failed to separate here. That's what OCT actually showing. If you look at historically last 4 decades, there are a variety of options in order to take care of the Peterson anomaly. Primarily, keratoplasty is reserved for a very severe cases. Considering the longevity of these children, often end up with one of the complications, may have an abysmal prognosis, considering the life expectancy of each of these child. I went through the 4 decades of all the published literature, and only about 20 to 60% of them select cases can have a 2400 and above with less than 4 years follow-up. We published in 2020 the last case, the last column showing the row, 30 case have a 97% success rate and having 2800 or better. Mind you, these are all small children, they are pre-verbal, and you have challenges in documenting their visual acuity. So one of the premise for this entire project is that what we found, biologically, there is an anomalous Descemet's endothelial complex. This is basically transcription abnormality. These abnormal cells inhibits the regenerative ability of the peripheral healthy endothelium. Therefore, these defects do not naturally heal. So by removing this inhibition, contact inhibition by virtue of the surgical removal, we are facilitating the normal endothelium to expand and results in a resolution of the scar and the opacification. This OCT you could see, this is an anomalous layer, and histopath also will show about anomalous layer, although they have a nascent or immature Descemet's membrane. So all we are doing surgically removing that anomalous layer. Also documented post-operatively, could see the 1 week post-op, there is a corneal edema, and at this is the 30th 1 month. So you could see a fine reflective membrane, perhaps suggestive of a Descemet's membrane, although it doesn't show about endothelium, it's a surrogate marker. So with this background, we wanted to test this hypothesis prospectively. It was started October 2019 onwards. It's an ongoing prospective study. And I've included here only those children who have at least crossed 6 months of follow-up. This is a surgical technique. It's a very simple, easy technique. First step is severing the communication between the corneal opacity and the iris colority, staining, establishing the defect size, and exactly analogous to the way we can, polish the undersurface of the anterior lens capsule, removing these abnormal cells and ensuring there is no DM detachment at the end. So that's it. Your surgery spontaneously heals. Cases which have a lens involved, we also remove the lens. And if the defect is much more than 7 millimeter, we add a sphincterectomy or a iridotomy. So the 6 cases where have a less than 7 millimeter had exclusively SEPA, and 25 eyes had a form of iridectomy, and only about 6 eyes where we have to remove the lens. And this is a sequential image of right and left eye. You could see this child has a little over 3 years follow-up, and you have a significant healing. And this is a partial resolution. This is a complete resolution. So for the variety of condition, we had a good outcome. And there is a significant improvement in the vision. Vision tend to continue to improve over the period of time. The risk factor for the partial recovery is the age and the severity of the disease. By 10 years of our work, both retrospective and extended study, we have actually shown there is a good outcome by doing a SIPA. This is our simple algorithm based on the mild, moderate, and the severe diseases. These are my references. Thank you.
We continue with Dr. Muralidhar for the next presentation.
Yeah, so Dr. Muralidhar, fantastic results that you have. So what was the age group, I just missed that, that you have done in these cases?
Yeah, it starts from as early as 6 weeks, and most of them are around 6 months age group. That's what the mean age.
You could get fantastic pictures in these children. How did you kind of manage to do the UBM and all that?
Yeah, because I had a good mentors who taught me, right from all investigations, including UBM, OCT, I do myself.
Okay. Do you give them anesthesia at that time,
Correct.
or?
Correct.
Okay. So what kind of anesthesia then?
We use sevoflurane
I
extensively.
see. I see.
Only
Okay.
inhalation, yeah.
Did you need, other than the CPAP, did you ever need in any child, did you need a PK or did you need something else that you needed to do?
No, madam. Our criteria were very, very strict. And of course, you have to have a lengthy discussion with the parents, considering the life expectancy and many things. So we excluded those cases which have a more than, zone 3, more than 7 millimeter.
Okay.
And you don't have even a small island of peripheral cornea remaining. So we went ahead with the keratoplasty.
Okay. And any comorbidities in these children? Did you ever have?
Excellent question. Yeah, the variety, right from optic disc, issues to, macular hyperplasia, and at least nearly 2/3 of them have systemic issues, right?
Like?
From cognitive impairment, cardiac issues, polycystic kidney, variety of systemic abnormalities.
So was it challenging to give anesthesia to such children?
Yes, particularly Peter Plus, you have that typical facial, configuration, everything. They have hypoplasia, macrognathia. Yeah, it is a very challenging from anesthesia point of view also.
And what was the frequency of follow-ups? Like how frequently were you following
This
them
has
up?
become simplified. Once we have
Okay.
a surgery, my next anesthesia would be typically 4 to 6 weeks. That is the time I remove the 2 side port sutures. That is the time I also document all the OCT, UBM, and also measurements, the corneal measurements, resolution, and so on,
So
including the retinoscope.
In the same sitting, you would do everything. So was it done in the OPD, your UBM and this and that?
So what I do, my OPD facility has a minor OR. So let's say I have typically about 90 is my pediatric OPD. Around 20 would be taken under anesthesia.
Okay.
So those cases which need a suture removal, need to revise any refraction, spectacles, or I have to check the intraocular pressure. If the eye care consistently shows eye pressure, so then I go and cross-check with the Perkins.
So did you need any AGM, glaucoma procedures, anything in any of
We
them?
have excluded all that had
Okay.
at outset. That's what, our outcome is 100% here. 100% of the cases had at least partial recovery. Nearly 60% had a complete full recovery. You could see that images. Full recovery means, we are able to see through the defect, able to refract, able to see the fundus, retina, everything. That's a surrogate measure, of course. And children also showed their visual fixation pattern, and the vision was continuing to improve because the child's, cognitive things are improving. They tend to do better. And most of them, 95% of them were all a pre-verbal age group, less than 3 years.
So none of them you needed to implant an IOL or anything. You just
No.
did lensas.
Correct.
That's,
I think, apart from, since it's a neurocrystopathy, they also have a trabecular dysgenesis and they have a microcornea. I don't think we should really embark on doing the intraocular lens in these cases, at least. Considering their lifetime, particularly type 2, have a 70% of lifetime secondary developmental glaucoma. Therefore, it should be avoided.
so it's kind of a multi-speciality thing. You need the glaucoma person and everyone to chip in there.
Including the pediatric person, in case if there is any squint need to be corrected.
A lot of cases, I would say, in this period.
How do you decide how much of endothelium to remove? In all the cases, was the same value?
No, great question. So one of the first step, I severed the communication and injected the trypan blue. It's sort of, it'll help you mark. And wherever polarity, from the polarity, this iris insert that define the perimeter of the corneal opacity. Okay.
So the reason why I'm asking is because you have taken zone 2 as well, and you also told the rationale is for the side endothelial cells to come in. So if you're doing the zone 2, obviously you're not going to take it.
Great question. That's what, particularly microcornea, if you don't have enough residual endothelium around, so they don't do well. So yeah, we should not take such a cases. Absolutely. You need to have at least 1/4 of healthy peripheral cornea. And we all know peripheral endothelial reserve is much more than the central. And we also believe up to 2 years, they may retain some amount of mitotic potential. So unlike, DSO, so this is a much more biologically, much better procedure.
And did you use any lock-in?
No. So the reason is, these peripheral cells are healthy cells. Unlike in a Fuchs, so they have a mutation there. Those cells, do not, proliferate or expand. So that's what you need something facilitate. Thank you. So I'll go on to my next presentation if you are just for me. So my second talk is on a CHED. It's a decade of our work. So earlier we published on an exclusively pediatric age group, 112. This work include all age group. I'll tell you why exactly we included that. Do not have any financial disclosure. Said we know bilaterally diffuse corneal clouding generally manifests immediately or at the birth, and it progressively increases thickening and opacification. And as the time progresses, you have a lot of morphological changes. Initially at the Descemet's endothelial complex, you have an abnormal Descemet's membrane being deposited. That's what, Descemet's gets thicker and thicker. Some of these cases have as thick as 50 microns. Normal Descemet thickness is around 10 to 12 microns. And also as the chronicity increases, it also damages the Bowman's membrane. I'll come to some of the investigation. So traditionally we used to look at torchlight evaluation, make a distinction mild, moderate and severe based on the high visibility of the iris detail. So in the first we don't have to do some time. In the second, certainly this case is for a DSEC. In a third case, because of degenerative pannus, maybe a penetrating keratoplasty would give a much better outcome than a DSEC. Although DSEC is evolving, have been found to be much more advantageous. We were the first one to consistently demonstrate DSEC in a pediatric age group. Although DSEC has been really good in several aspects, but if you look at between these two images, you will never get a pristine clarity of a penetrating keratoplasty after a DSEC. Meaning it is a big compromise trade-off, because it gives you all advantages of suture-less surgery, early recovery, much less risk of glaucoma, graft-dose dehiscence. But one of the biggest setback is a lack of corneal transparency. So for this, what we did is that we started analyzing this. We started using what are new devices which we have. So not only what I did is that, this is the traditional classification, mild, moderate, and severe. We started using the morphometry and also densitometry. If you look at densitometry, seems to be much more robust and a reliable marker of the disease than a OCT or a corneal thickness. So this also reflects, you have, as I said, you have anterior basement membrane fragmentation, Bowman's membrane fragmentation. So that clearly reflects, this is perhaps one of the important reasons why these corneas tend to be much more easier, and therefore how do we address? And also the scatter plot actually showing the densitometry has a very narrowly placed, so it is a very robust measure compared to the CCT alone. So therefore we proposed a new algorithm based on the findings, meaning you have to do a clinical clinical photography, and if the child is cooperative between 3 to 5 years, I think that is the age group, they can cooperate for this imaging. And based on a mild, moderate, and severe, we have a new algorithm. And most endothelial keratoplasty do well if we choose, moderate cases, moderate to mild cases, not the severe cases. So you have again a mild, moderate, and severe. If you have a OCT changes, I do not do DSEC. Some of these cases have an extremely good pristine cornea compared to that of a PK. Okay, so we try avoid, this is a case which is a 12-year-old child who had a DSEC. Apart from the corneal haze, can you see some striae? This we coined this term called as a Bowman's membrane striae. So this is particularly appears, because of folds in the Bowman's membrane. And some of these denser cases we've also combined with the mice. And with the mice to begin with, younger tissue, much more better endothelial reserve. So therefore I wait at least 3 months, 3 years is the minimum age.
Excellent study.
Did you have
By
any?
then, child also cooperate, use slit lamp. You don't have to take, several time under anesthesia. They also cooperate you for all imaging. I think that is a good standard, between 3 to 5 years. They also start to the formal education where child visual requirement or demands are much higher. That would also facilitate them.
Any specific measures you take then to improve the amblyopia after that? Anything specific?
Yeah, I think 3 months, we were able to refract. I gave them prompt refractive correction by 3. And once child acclimatized to the glasses, then I start doing alternate eye patching. And we have a plethora of applications, apps, visual stimulating apps. I run them through the parents, and also we have a rehabilitative facility. So we'll try to, stimulate and try to, catch up, the 3 years which, child had lost so many things.
In all your cases, you did the stripping technique or the non-stripping technique? In all your cases, did
Excellent. So I couldn't show the video. So what I do is I make a side port, inject the air bubble, which will serve as a concave mirror, and it will show up, are there any gutty, pigments, any scar. If I don't see anything in the visual axis, I believe we should do a non-Descemet stripping. The reason is Descemet is very thicker, and it is time consuming, very tedious. In the process, you may injure lens, iris, okay? And also most often, so we dig inside, we end up peeling the lot of posterior stromal fibers. So almost 10 years ago, I published that series, Descemet stripping versus non-stripping. So non-stripping seems to be very, very superior, yeah.
And during the course of the surgery, did you do any other technique to enhance the visibility, like use light pipe or
chandelier elimination. And certain cases we also, stain them if needed.
Did any of the children need cataract surgery later on?
Yes, madam. I think 23% of these cases, I believe, following a simple trabeculectomy, uncomplicated trabeculectomy, we have a 5-year, cataract formation. I believe, the cataract is the biggest risk. I think, nearly 1/4 of entire series had some form of a cataract. Possibly it could be combination of, intraocular insult, manipulations, and also long-term use of steroid. Also, I deliberately make an attempt by 1.5 years. We will wean them off as steroids. But even then, we had a nearly 23 to 25% of them had a.
And how did the graft behave after the cataract?
Okay, and so only about 12% out of this 23 had a visually significant. I generally do myself retinoscope and see if there is a nodal point is obscured, and they tend to do well. So far, I was lucky, didn't have any graft failure.
Okay.
But these children, we also do the specular just prior to the cataract surgery and take all necessary precautions. Since it is just lens aspiration, I believe we don't use a phaco energy. I think that actually one of the big advantages.
Okay.
your technique for insertion?
Okay, I use a sheets glide. I recommend, we should master one particular technique, not to mix and match, so that I'll avoid, putting ACM, AC main tunnel and so on. And you have one main tunnel, one side port. So no more ports. Thank you.
Thank you, Dr. Muralidharan.
Thank you.
I call upon Dr. Vineet Joshi. Yeah.
Is the topic changed? He
Okay.
says topic.
Thank you.
He has changed that topic.
Thank you for giving me this opportunity. Today I'll be presenting on a novel technology that we have been trying to use in our research. I'm Vineet Pramod Joshi. I'm faculty at LB Prasada Institute, Shantilal Sangvi Cornea Institute. And these are my co-investigators. And I'm also currently pursuing a PhD from Biomedical Engineering Department at IIT Hyderabad. So I represent this robust team from different cadres from Center for Cellular Microbiology, Hyderabad, as well as IIT Hyderabad, along with our team at LVPI. And we are working towards the main problem of corneal blindness. And this is primarily due to stromal scarring. Although internationally, WHO has said that this is the fourth common cause of blindness. Up to 4.2 million bilateral blindness cases are due to corneal blindness. That is not entirely true to our part of the world and the African subcontinent, where it happens to be the second most common cause. And actually 98% of the world's corneal blindness is in these two main subcontinents. More likely it affects the young population, mostly due to infections and injuries, which actually lead to a lot of disability adjusted life years. So the overall impact of corneal blindness is very high. We have also seen that most of these people who need transplants, they are already of fair to poor prognosis for transplants. So basically they will land up into failures. Their 5-year survival rates are also very poor, and mostly the common reason is infections and trauma. To add to that, if you see the iBanking status results, the utilization of iBanks across the world is up to 53 to 60%. That means 40% of the tissues are still wasted and they can be used effectively. And still 53% of world's population has no access to transplants. So there is a huge loophole where actually we can find out any stromal alternative or any alternative to cornea as a transplant. So what is the aim? We want optically clear, mechanically strong, a material which can give you the ideal curvature and shape, and most important, integrates well into the host tissue. So many experiments have been done by different groups across the world. They have tried synthetic materials, natural materials, and they have tried using the technology of 3D bioprinting, like using gelatin methacrylate or some other cellulose compounds. Some have even tried combining natural and synthetic elements. Now newer 3D printers are coming. I will try to simplify it. There are many 3D printers. So they are trying to use laser-based, light-based 3D printers to print. These are some of the studies from China as well as some groups in Sweden. But what we approached, we used the extracellular matrix approach. What we believed is that, okay, so some of the slides are missing out. So we took the extracellular matrix approach, wherein we decellularize the wasted tissues from the eye bank, and we took that extracellular matrix and we applied it in our animal model, which we validated it in-house, a rabbit model where we developed scars which were equivalent to humans post microbial keratitis scars after treatment of 2 months. And we tested these rabbits on clinical imaging profiles like ASOCT, topography, and densitometry. So what was the first? Okay, so these slides are not coming correctly. Okay. So what we did was we identified 2 tissue sources. One was bovine and one was human. And these corneas we took and we decellularized in our IIT lab. And we took this decellularized extracellular matrix and we tuned its physiological properties such that it becomes a gel at room temperature. And this gel now can be used through the 3D bioprinter to print in whatever shapes that you want and actually use it as a bioprinted construct. So we found that we actually introduced a 200 microns defect, and which eventually led to scarring at day 90. In the positive control, we just put type 1 collagen. Now in the middle 2 rows is the human decellularized matrix and the bovine decellularized matrix. And if you can follow them till the end, you can see that the opacity which started to develop by day 14 was resolved by day 90, which means that this decellularized matrix somehow prevented scarring. And actually not only prevented scarring, it actually gave a good smooth corneal surface, as you can see in the ASOCT maps, and also restored appropriate thickness. On histology, we also saw a normal epithelium grew over these constructs, which was equivalent to normal cornea, and the content of this was equivalent to the normal cornea, which was type 1 collagen, you can see in the golden color. While in the scar control, you can see it's a green colored collagen, it is type 3, which was seen in the positive and the negative controls. Again, the expression was such that the cells, the keratocytes which migrated from the sides, were expressing keratin sulfate, which is what you actually want. So going ahead, we are trying to 3D bioprint this. This is one of the videos of 3D bioprinting of this cornea using this decellularized matrix, and you can now customize it to any shapes, any sizes as per the requirement of the cornea surgeon, any thickness, and try to implant this. So we are now at the stage of animal studies to implant these 3D printed corneas into animals and get some early results which are quite promising. So going ahead, we found that this is a very easy, available, simple formulation, easy to administer. This can be suturable if you add cross-linking methods to it, and it also promotes healing and prevents scarring. Thank you.
So very nice study, Dr. Vineet. I would just like to ask you, till what thickness of the cornea would you think?
So this experiment we did at the depth of 200 microns, And now when we want to go for deeper opacities, we can go for wider and deeper opacities up to 400 microns depth also. So this experiment was at the depth of 200 microns and probably a gap of 3 to 4 millimeters, which was filled with the hydrogel alone. The second experiment is what we are doing now, is we are taking 6 millimeter constructs, we are going up till 400 microns depth, and the same size we are feeding into the CAD model into software and printing the lenticules of that size and implanting it. As of now, we are not putting any sutures, we are fixing it just with fibrin glue, just like Falk procedure.
But why did you take bovine? Bovine is not really kind of. It's quite thick, isn't it?
We were looking for once it's a gel, it's actually same, so
I
it's not
see.
problem. But we wanted to look at alternatives to human sources. But during the COVID time, we found that regularization and quality control standards for animal sources is very difficult. So since already iBanking and standards are well set, we went ahead with first utilizing the discarded human corneas. Side by side, we are working at different sources of tissues as well, because this methodology is working. So we can implement various different
Porcine
sources.
is pretty much closer, right?
It is closer, but again, animal source, we
Okay.
have a
Now,
lot
is
of
the
strict guidance.
biomechanical strength? How do you assess the biomechanical strength?
Biomechanical strength can be assessed by two ways. First, you need to cross-link it at different levels, and then we have in our labs we have this young modulus that you can test. Then there is bursting pressure, where you can fixate it, or like if you can suture it, you can suture it, or you can fill it into the defect, and then with the anterior chamber you can fill it with a pressure with a barometer until it bursts. And then we have these for Young's modulus, we have this stretch strain curves, we have the normal values for the normal corneas and for crosslink corneas, and the same we develop for these ones. We have all the data, but I agree that we need to improve on the crosslink. So there are various new chemical crosslinkers, not just riboflavin, which we are experimenting, and that actually crosslinks faster and gives you a very nice stability and strength.
And the scars were actually decreasing in density, or what?
So that was a novel finding. We did not actually go for that. We were looking for a material which can replace the stroma, which we can 3D print. But the material itself prevented scarring. So probably it is a theory of stem cell secreting good factors, and those good factors preventing the scarring. We are directly using those good factors in the form of the
Preventing scarring, or the existing scarring is decreasing?
So if you see in those controls, when that 200 micron cornea was removed, in a period of 90 days it scarred. So when we filled that gap with the hydrogel, it did not scar. So that's why we can say it actually prevented the scarring.
Interesting.
Okay, this hydrogel, does it stay in the same state after you implant this, or it solidifies?
So it has some unique properties at 37 degrees, and if you maintain that temperature and pH, it will start gelating.
Okay.
And you can customize it by different chemical crosslinkers if you need certain amounts of.
Okay, so I think maybe this temperature variation also you require to see, because if the patient say visit to a colder area, suddenly if his corneas opacify, or if he goes to a very say desert, then something else happens. So that aspect can also be looked into.
I totally agree. I mean, till coming to the patients is still very far, because as you mentioned, these points we first need to examine. The idea here is to create a stable compound which biointegrates.
Absolutely,
well.
absolutely.
Most of these.
So this is the first step towards that, and it's I think marvelous. It's very good. This thing.
Most of those lenticules which were shown earlier, they actually are very good to suture in, but they don't integrate. That interface gets evaded by epithelium and vessels. So this is where nothing happened. So we are hopeful that we have some good product at hand which can be modified to all various needs.
Yes.
Thank you.
Thank you.
I call up Dr. Savitri. Shweta.
Savitri.
very good morning to one and all. So I'm Dr. Savitri and I'll be presenting on topography guided removal of epithelium in keratoconus with cross-linking its 5-year outcomes. So at the outset, I would like to declare that me and my co-authors don't have any financial disclosure. So manual cross-linking has stood the test of time to arrest progression and is known to achieve stability. But at the same time, there is no improvement in visual acuity in many of the patients, and in many cases, we have to finally resort to rigid contact lenses for visual rehabilitation. But with the advent of laser-based cross-linking now, we can achieve both. So how do we go about this? Any patient having less vision and having a coma value of more than 1 micron is checked for the thinnest corneal thickness. If it is more than 450 microns, we can go ahead and plan a topography guided PRK treatment, which can be corneal or ocular wavefront guided. On the other hand, what if the TCT is less than 450 microns? What if the theoretical mean corneal thickness after ablation goes below 400 microns, or if the maximum stromal ablation exceeds 40 microns? If we plan a corneal or ocular wavefront guided treatment in such kind of corneas, we would lead to ablating a deeper layer of the stroma, and which will cause excessive scarring. So for such kind of eyes, we have devised a novel tissue sparing approach, which is known as topography guided removal of epithelium in keratoconus, that is TREC. So TREC essentially is a cyclotorsion compensated localized trans PTK, wherein PTK is performed at a depth of 15 to 20 microns along with the thinnest epithelial thickness. So how do we plan this? First of all, we localize the cone on the anterior tangential curvature map. Then we identify the long and the short axes. Then we perform a PTK over the area of thinnest pachymetry along with 15 to 20 microns of stromal ablation. Then manual removal of the epithelium around the cone area is done, which is followed by accelerated cross-linking. So here we can see that in the same eye, TREC is ablating lesser amount of stromal tissue. So what are the benefits that it offers? It gives a better abrasion profile. It regularizes the cornea. It ablates a very less amount of stroma. It gives improved visual quality and enhances the contact lens fit or the spectacle acceptance. So one would want to ask if it is comparable to TPRK. So yes, we found that at 1 year, both of them were doing very well and had improved visual acuity. But the TREC was shown to have lesser stromal tissue ablation. Does it also work in the long run? So to answer this question, we followed up about 78 eyes for a period of over 5 years. Patients ranging from 18 to 35 years were included. Keratoconus with decentered cones documented KC progression, thinnest pachy of less than 450 microns, and maximum planned stromal ablation of more than 40 microns were included. Whereas on the other hand, patients not willing for laser-based surgery, advanced KC with scarred corneas, and thinnest pachymetry exceeding 450 microns were excluded. So these patients were first imaged on Schwind-MRS, and then TREC was planned for them. In the same sitting, accelerated cross-linking was done. So we used 0.1% riboflavin every 2 minutes for 20 minutes, which is followed by 9 milliwatt per centimeter square of UV exposure for next 10 minutes. So we found out that the efficacy index was 3.26. And coming to the safety part of it, so 40% of them gained 1 line after TREC and 55% of them showed no change. Sorry. The keratometry values were found to show statistical significant decrease. Coming to the astigmatism, so the refractive astigmatism, the mean was decreased from 4.54 to 4.55, but it was not found to be significant. The corneal astigmatism, though, was found to be statistically significant. Then change in the abrasion, so decrease in the lower and higher order abrasion was found to be statistically significant. Then does it make the cornea weaker? So as a part of our ongoing project, we imaged these corneas on pre-operative visit and then post-surgery on our polarization sensitive OCT. What we found out that the collagen in the central cone area was now more densely packed, and which was suggestive of an improved structural integrity of the collagen post-procedure. So these are few case examples which have shown flattening following TREC procedure. Coming to the complications, there was a progression in one eye out of the total 78 we had taken. There was loss of line of one line in 3% of cases, whereas there was excessive flattening was not seen in any of the eyes.
So what we knew from before was that TREC is an innovative technique which is useful in advanced keratoconus with thin, steep corneas, which is not amenable to regular laser-based cross-linking. It is a tissue-sparing technique which precludes scarring. The results are comparable to TPRK in the one-year outcome analysis that we had done before. What our study adds is that it is an innovative technique, and now it is showing good outcomes even with the 5-year data analysis. The efficacy has been proven now at the ultrastructure level in terms of the strengthening of the collagen, which was imaged on the polarization sensitive OCT. It's a novel technique to offer safer laser-based cross-linking for thinner corneas. Thank you. That's all from me.
What was the thinnest that you took in this?
So ma'am, our main aim is that the stromal ablation should not go beyond 40. So in TREC, it goes usually around 10 to 15. So along with the epithelial thickness. So what we do is we first image the epithelial thickness in the cone area. We take the lowest value and then add the stromal ablation, which is around 10 to 15. So our main aim is that after ablation, it should not go below 400. Or in some cases, 380 is also acceptable.
Any questions?
Thank you.
Okay.
The following technique, you notice any scarring or any haze or anything?
No, sir, not at all. It's basically a PTK, sir. So it was not found, sir.
Dr. Shweta is available? Yeah.
Okay. This is?
Next is Dr. Shweta.
Case series of infectious scleritis.
This infectious scleritis? Not
What is one?
ये ratified member ये वाली है.
Yes, ये वाली है. Second last on this COVID pandemic.
Good morning to one and all. I'll be presenting a case series on infectious scleritis in the backdrop of the COVID pandemic. No financial interest. Introduction. Scleritis, a painful inflammatory disorder with sclera, is mostly caused by an immunological phenomena, and nearly 50% are associated with the collagen vascular disease. Infectious scleritis is rare, accounts for only 5 to 10% of all the cases. Orbital mucormycosis, follicular conjunctivitis, episcleritis are few of the various ophthalmic manifestations of COVID reported in literature. Here we present a cluster of cases of infectious scleritis that we have seen during the third wave of the pandemic. It's a retrospective case series in the duration of December 2021 to February 2022 in the Department of Cornea and a tertiary eye care center in South India. 5 cases of infectious scleritis that were culture proven were taken for a study. Any clinically suspected case of infectious scleritis that were culture negative was excluded. A detailed retinal examination was performed. The scleral abscess was surgically drained and sent for culture. The patient was started on empirical topical and oral antibiotics till the culture report is available. Then the treatment was modified as per the culture report and susceptibility testing. A repeat drainage was performed if necessary. The incidence of infectious scleritis in our institute was noted in the pre-COVID as well as in the three-period time. UBM was performed to delineate all the pockets of scleral abscess. Under general anesthesia, the conjunctiva over the scleral pus nodule was incised. The scleral pocket was opened. Pus was drained and sent for culture. All the granulation tissue was removed. All the scleral pockets were explored. Antibiotics and betadine wash was given. Cryo was applied to the edges of the lesion. The conjunctiva was just opposed and the wounds were allowed to heal by secondary intention. All the patients were simultaneously given topical and systemic medication. There were 3 males and 2 females with age ranging from 36 to 69 years. None had a history of surgical or accidental trauma. 1 patient had a history of diabetes and hypertension for the past 20 years. The duration of symptoms lasted for 3 weeks to 4 months in the range of with a mean of 2.15 plus minus 1.22. Clinical presentation, 3 of our patients presented as monofocal scleral abscesses, 1 with a scleral abscess associated with a corneal infiltrate and 1 with a multifocal scleral abscess. These are the culture and sensitivity profile. 3 of them were nocardia, 1 was Aspergillus fumigatus and 1 was atypical mycobacteria. The nocardia was multi-drug resistant to cotrimoxazole and cephalosporins, but was sensitive to linezolid and amikacin. These are few of our clinical cases. The first one was a scleral abscess that presented at 6 o'clock associated with a corneal infiltrate. This is one other case which presented with a scleral nodule with a pus pointing. The last was a multifocal scleral abscess that healed with scleral thinning. These are the two of our cases required repeat drainage. This is a 36-year-old male who presented with infranasal deep scleral congestion, a scleral nodule, and a pus point. UBM showed a hyperechoic dome-shaped lesion. Empirically, he was started on 5% cefotaxime, 2% amikacin, and tablet moxifloxacin 400 mg OD. The abscess was drained on the second day, and culture on the day 4 showed chalky white colonies of nocardia. Injection amikacin 15 mg per kg was started, 0.6% linezolid eye drops, and 2% amikacin was started, eye drops as well, were continued. On the day 14, however, the scleral pus nodule reappeared and hence a repeat drainage was performed. Topical and systemic antibiotics were continued and the lesion healed with scleral thinning. This is another case which required repeat drainage. He was a 69-year-old male, diabetic and hypertensive for the past 20 years, presented with multifocal scleral abscess in the inferior and the temporal quadrant. He was also empirically started on 5% cefotaxime eye drops, moxifloxacin eye drops, and injection cefotaxime 1 gram BD. He underwent the scleral abscess drainage on the same day. Culture showed nocardia again, which was multi-drug resistant but sensitive to amikacin, linezolid, and povidone iodine eye drops. 12 days later, a new pus point developed nasally, hence a repeat drainage. Finally, the lesion healed. One patient developed a complication of exudative retinal detachment. During a period of 2018 to November 2021, that was pre-COVID, we have seen about 1.6, hardly 1 to 2 cases of scleral abscesses in our institute. But during this 3 months time period, we saw 5 cases of infectious scleritis from December 2021 to February 2022. The predisposing factors that have been known are ocular trauma, previous ocular surgery like pterygium, cataract, retinal detachment with scleral buckle. However, none of our patients gave a history of significant ocular trauma or recent ocular surgery. There was a surge of cases of COVID during the second wave of the pandemic that have been associated with increased reporting of invasive mucormycosis. The risk factors have been many and include diabetes, uncontrolled, the excessive use of steroids during the same time, cytokine storm associated with COVID. During the third wave, which hit India from January to March, during the same time period, we have seen increased reporting of infectious scleritis cases to our clinic, which would suggest a probable immunosuppression. Nothing else as a confounding factor except for the backdrop of COVID. The limitations of our study, however, are that COVID antigen testing, RT-PCR testing, and COVID antibody testing was not performed for the patients during this time period due to the retrospective nature of the study. Also, patient did not report any active symptoms suggestive of COVID at the time of presentation. These are my references. Thank you.
So you were on COVID positive, is it?
Yes.
Thank you, doctor. We're running short of time. Can I call Dr. Ritika Mukherjee? She's there.
We'll just put the numbers. Take a call. They have already mentioned.
Dr. Shivi, you can be ready with your presentation. Dr. Shivi is present.
Okay, not to be.
Good morning, everyone. So I'll be talking about the impact of cyclical variation of hormones on the ocular surface health and wound healing. So when we consider the systemic and ocular surface immune biology during the menstrual cycle, we have seen that there is a role of cyclical immunity. The ovarian cycle causes fluctuations in the inflammation, and there is an alteration in the balance between the cellular and humoral responses. And this influences the autoimmune disease symptomatology. We've seen immune diseases like RA worsening during certain phases of the menstrual cycle. So our problem statement comes from the fact that we see many patients who have similar grades of keratoconus, who have undergone cross-linking but shown variable outcomes. And we know that the ocular surface is an estrogen-dependent unit. So ocular surface inflammation and an abnormal immune milieu can affect post-op outcomes of refractive surgery as well as patients of keratoconus. There is very limited research available on this ocular surface immune and inflammatory milieu in different phases of the cycle. We do know that the ocular surface shows changes in its structure. There is a thickening of the epithelium, and this mirrors the cyclical variations in the hormone levels as well. So this brings us to our research question. Does the ocular surface and tear inflammatory cytokine milieu change during the different phases of the cycle? So we conducted a prospective observational non-randomized comparative study with 15 healthy women without keratoconus and 15 healthy women with keratoconus. And so we performed the Schirmer's test and the non-invasive breakup time as well as the tear fluid soluble vector analysis in different phases of the menstrual cycle. And what we found was that the biomarker assay was done using the tears which we collected from the Schirmer strips, and we put it in the world's first point-of-care diagnostic test, which we assess multiple tear biomarkers. Basically, it uses a microfluidic design and fluorescence to test for tear-soluble factors raised in inflammation, such as interleukin-6, interleukin-8, MMP9, etc. And it generates a test report which gives the concentration of these 8 analytes along with their normative range in the tear fluid as well as in the aqueous. So what we found was that there was a reduction in the Schirmer score values as well as the non-invasive breakup time during the ovulation phase. And a greater number of eyes showed an increase in the tear fluid levels of interleukin-1 beta, 6, MMP9 and VEGF. These inflammatory cytokines were specifically raised during the luteal and the ovulation phases. So to understand the impact of menstrual cycle on the post-surgical wound healing, in a normal response when the inflammatory markers are raised, they give rise to conversion of keratocytes to the myofibroblasts, but within 24 days, they will go back to normal and the wound remodeling will start. However, if there is an increase in the inflammatory biomarkers, these myofibroblasts persist for a longer time. They may get converted to fibroblasts, which lay down aberrant collagen and cause scarring and abnormal post-surgical wound healing. So there has been an association of the sex hormones with ectasia pathogenesis as well as aggravation of dry eye symptomatology. This could mean that whenever estrogen is raised, it causes a stimulation of the matrix metalloproteinases as well as inflammatory cytokines, and the cyclical variation in the estrogen as well as progesterone levels during different phases also results in a cyclical increase in the tear inflammatory cytokines. So the significance of this would be in patients who have an hormonal imbalance due to PCOD, hormonal contraceptives, or due to menstrual irregularities, may have aberrant outcomes post cross-linking or may also have poor wound healing after refractive surgery. So this is what we knew, that it does have the ocular surface immune and the inflammatory changes does affect the keratoconus pathology, and it has a role in the dry eye symptomatology. We also know that the cyclical changes in the corneal thickness are there and it is sensitive to the menstrual cycle. But what we now know is that there is a definite increase in the tear fluid inflammatory cytokines during different phases of the menstrual cycle, and that this may cause aberrant wound healing post-surgery and also abnormal outcomes post-cross-linking.
Them and my team for helping me present this work on their behalf. Thank you.
I think we'll go to the next one.
No, next one I think
Last one.
yes.
Dr. Shivi.
Start the presentation, please. AD team.
Shall I start? A very warm good morning to everyone present here. I'm Shivi Srivastav, second year resident from LLRM Medical College. And the aim of my study was to analyze the functional and visual outcome of corneal grafts after therapeutic penetrating keratoplasty in patients of fungal keratitis. There has been no conflict of interest and no financial interest to disclose during the study. So we begin with what is TPK. Therapeutic penetrating keratoplasty is a surgical procedure in which a diseased cornea is replaced by a healthy donor cornea with the main purpose to restore the structural integrity of the eye, to resolve an infectious or inflammatory keratitis which is refractory to conventional medical therapy, and to eliminate pain. Therefore, it is the surgical procedure of choice when all these indications are present, such as in case of a corneal ulcer that has been unresponsive to medical therapy or has perforated. Mine was a hospital-based surgical interventional prospective study conducted in the upgraded Department of Ophthalmology of LLRM Medical College. OPD patients who had non-healing fungal corneal ulcer underwent detailed ophthalmic examination, and 20 eyes were selected for therapeutic corneal transplant after obtaining an informed consent. All glycerine preserved grafts were used. Patients of all ages and either sex who were not responding to antifungal treatment for 2 to 4 weeks, or the patients who had corneal perforation or impending perforation following fungal corneal ulcer were included in the study. However, patients of non-infective ulcer, patients of corneal ulcer in previously grafted cornea, patients of bacterial keratitis, fungal keratitis with endophthalmitis, patients who had poor tear film or lacrimal sac disorder, patients who denied PL or had inaccurate PR, patients who refused for the study and not willing to come for follow-up, patients with history of any retinal, macular or optic nerve pathology that may hamper the vision, and the patients of penetrating keratoplasty was done for other indications were excluded from my study. We see the following photographs of the patients who underwent surgery. These two cases had excellent post-operative visual outcome. In the first case was of 636 and in the second case was of 660 after 6 months follow-up. This patient, however, had graft failure. We see superficial vascularization due to recurrence of host pathology. In this patient, in the first case, we can see the folds on the cornea due to tight sutures. In this case, the post-op day, on the first post-op day, the visual acuity was of 0.5 meter finger count. The results of my study were that the maximum incidence was seen between the age group of 41 to 60 years, in which out of the 10 patients, 7 were male and 3 were female, followed by the age group of 21 to 40 years, in which out of the 6 eyes, 4 were male and 2 were female, followed by the age group of more than 60 years, in which out of the 4 patients, 3 were male and 1 was female. We see that 50% patients presented with non-healing ulcer, 15% patients had impending perforation, and 35% patients had perforated corneal ulcer at the time of presentation. 45% patients had pre-op visual acuity of PL positive PR accurate, whereas 55% patients had visual acuity of finger counting close to face to hand movement. Average post-op visual acuity after 6 months period was 618 to 660 in 10% cases, 3 meter finger count to 6 meter finger count in 5% cases, 1 to 3 meter finger count in 50% cases, that is in the majority of patients, hand movement to 1 meter finger count in 30% patients, and PL positive PR accurate in 1 case, that is 5% patients. So we see that 85% patients had therapeutically successful graft and 15% patients had failed graft. The reason for failure, out of these 3, 2 had immune graft rejection and 1 suffered recurrence of host pathology. Actually, host pathology recurred in 2 patients, but 1 was medically controlled and did not amount to graft failure. From our study, we conclude that corneal transplant has success unequaled by any other organ or tissue transplant. 85% patients had therapeutically successful corneal transplant, out of which 10% achieved an excellent visual acuity of better than 660. Thank you.
Okay, Dr. Shivi, why did you use glycerin preserved corneas?
Sir, because we have eye bank in our department, in which there is a long list of waiting patients, and we go to retrieve the corneas, and we need to store them for a little longer time because we need to call the patients, investigate them, and then we plan them for surgery. So for that time, because in glycerine we can preserve the graft from 30 days to 1 year. Like it is
And you had the photographs that you show. These were glycerin preserved cornea post transplant?
Yes, sir.
Okay.
What's your membership number?
Ma'am, it's there in the presentation. S.
Show me the first slide.
First slide, yeah.
It's there in the first slide.
Show the first slide, please. Pehla wala slide.
It doesn't look like that.
What is this logic here in IBAN?
No, that is there in every IBAN. You just create the tissues. If they can't use a
Ma'am, S26354.
B minus
26354. And that too in non-COVID time. This is criminal. Fine. Thank you. Thank you to all the presenters. Your marks will be available at the AIOS, but scientific committee, right?
Yes. I think we request all the presenters to come on the dais for a group photograph with.
We need to tell first. Ratified name.
This one? Last presentation.
S265.